Welcome, ladies and gentlemen. Gentlemen, just bear with me on this. This is important if you have a female spouse or partner. You want to be able to give them information on hormone replacement and support them in their journey to optimization of their health. So I wanted to just take a little bit of time to explain the difference between bioidentical micronized progesterone and progestins. I know the medical literature tries to muddy the waters and call them all the same, but trust me, they're not. And I've taken the time to write something up to kind of explain that. I don't want to miss anything, so I'm going to refer to what I've written up a little bit. So if you see me take my eyes off the camera, that's because I'm just trying to maintain what I've written down here. So not all progesterone is the same, as I said, and this distinction matters far more than women have ever been told. In menopause care, progesterones are often treated as interchangeable, as I mentioned, but the medical literature tells a very different story, especially when it comes to breast cancer risk, brain effects, and mood tolerance. So today we're going to break down the difference between oral micronized progesterone, MP, and synthetic progestins, what the data actually shows about breast cancer risk, and what options exist for women who cannot tolerate oral micronized progesterone, particularly those who experience worsening of mood. And I'll kind of delve into that in detail. This is not opinion. This is epidemiology, physiology, and pharmacology. Let's start with the most important clarification. Micronized progesterone is bioidentical to the hormone produced by the human ovary. It's the exact same molecule. Now, something that a lot of people don't talk about is the micronization actually matters. One of the best products out there is exorbitantly priced. It's called Prometrium. Basically, it's so effective because when they make it, they micronize the particles so finely that it can be absorbed very, very well. I have found in my many years of practice that they're not over the counter, but the generic forms of progesterone are not as well micronized, and therefore the absorption is not as good. And I've seen this in labs where I've got a woman taking a really good micronized progesterone, maybe from a compounding pharmacy, at maybe even a little lower dose. Maybe let's say we've got it compounded at 180 milligrams versus the normal 200 milligrams, and their levels are, so my goal is to have it above 3, but let's say their level was 2.5. And then we put them on 200 milligrams or 20 milligram improvement, but they get a generic form because it's cheaper. And their level goes down to 1. I'm taking 20 milligrams more, my level went down. Yes. I'm getting less progesterone. No, you're getting more progesterone. You're just not bioavailable. You're not getting more bioavailable progesterone. So, doing the labs, especially in a menopausal woman, to ensure optimal levels of micronized progesterone, to me is imperative because we want to ensure the main thing that we're trying to do there is ensure that we are protecting the uterus from unopposed estradiol causing uterine cancer. We're increasing the risk of uterine cancer. So when we give estradiol to a woman who has an intact uterus, we must give progesterone. We want to give the most effective form. Now, I also feel that giving micronized progesterone to a woman who has had a hysterectomy, who's had her uterus removed, right, that it's important as well. And I'll go into that based off of the effects of progesterone on the female form. Progestins, on the other hand, are synthetic molecules such as medroxyprogestin acetate. And I'm going to fumble with some of these words because I don't use these products. And so it's hard for me to pronunciate them appropriately. Norethindrone, and or levonorgestrel, levonorgestrel. And I apologize because I don't use these terms often because I stay with micronized oral progesterone. But the progestins, such as medroxyprogesterone acetate and levonorgestrel, are designed to bind to the progesterone receptor, but with off-target effects. You might ask yourself, well, why are these even in existence? And the answer is because you can't patent what's available in nature. But if you come up with your own formulation, well, you can patent that. And that's what these pharmaceutical companies are doing so they can improve their bottom line. We're not talking about health. We're talking about money there. So just bear that in mind. Those off-target effects matter. Synthetic progestins activate glucocorticoid and androgen receptors. They reduce sex hormone binding globulin. They increase insulin resistance and IGF-1 signaling. So if you remember, one of the things that we talked about in the last episode was the effects of estradiol and in promoting the ability of glucose to be utilized by the brain cells. If you take a progestin with estradiol, you may blunt that effect because of the progestin's insulin resistance effect at the cellular level. That's why we don't recommend it. And they amplify estrogen-driven breast tissue proliferation. So if we look back at the Women's Health Initiative, and this is where everybody got things ass backwards, and they said, oh, well, I think they said it right, but it was interpreted wrong. They said, hormone replacement increases the risk of breast cancer. Well, that, by their study, was true because when they look at the overall hormone replacement that they did in giving women conjugated equine estrogens and medroxyprogesterone acetate, the group that got both had an increased risk in their breast cancer. It wasn't much, but it was an increased risk. Now, if we just gave the estrogen, and I'm not saying estradiol because it was estrogen, conjugated equine estrogens, there was a reduction in risk of breast cancer. So the relative risk for everybody on anything is 1.0. Anything above 1 is an increased risk. Anything below 1 is a decreased risk. So the risk of breast cancer went to 0.9. So there was a 10% decrease risk factor for breast cancer. When they gave the MPA, it went to 1.3 something. It might have been 1.27, but roughly 1.3. So there's a 30% increase from baseline. And they took that information and said, it's the hormone replacement. And then how did that get translated? Estrogen gives you breast cancer. Meh. Wrong. But it's important to understand that. So going back to micronized progesterone, it does not exhibit any of those properties. The pharmacological different forms, go back. Can we edit that? Yeah. This pharmacological difference forms the biological basis for the divergent cancer and mood outcomes we clinically and epidemiologically see. This is where the conversation must be precise. We'll edit that out. This is where the conversation must be precise. One of the strongest data sets available is the French E3N cohort, which followed over 80,000 postmenopausal women. Here's what they found. Estrogen combined with micronized progesterone showed no increase in breast cancer risk compared with women who never used hormone therapy. Relative risk was essentially 1.0, meaning neutral risk. In contrast, estrogen combined with synthetic progestins increased breast cancer risk by 16 to 69% depending on the progestin used. This elevated risk appeared even with short-term use. These findings have been replicated across cohort studies, case control studies, and meta-analysis comparing progesterone versus progestins. This is one of the things in science that we want to see is reproducibility of a study. And a lot of people talk about, oh, I read that metformin is a great anti-aging drug. Well, they had one study showing the benefits of metformin, and since then that hasn't been to be replicated. So that really brings into question that study. Kind of going off topic, but these are things that we want to know. Has the study been replicated? If you can't replicate it, the results are suspect to say the least. The British Medical Journal and other systemic reviews consistently conclude the type of progestogen, not simply the presence of one, is what drives breast cancer risk. Importantly, micronized progesterone does not increase breast cancer cell proliferation in human tissue studies. Synthetic progestins clearly do. And so just to help you understand how confusing this is, especially for healthcare providers, look at the different terms I'm using based off of the literature. So we're talking about micronized progesterone. So it can be called progesterone. It can be called a progestogen. It can be called a progestin. They interchangeably use these terms. But if the study actually is using micronized progesterone, it will indicate it is micronized progesterone, and it will not confound you and befuddle you with the different other terms. So that was what made it easy for me. When I see progestogen or progestin, I know the study I'm looking at is not using micronized progesterone. And I still read it because I want to see all the bad stuff that's happening with this. In my opinion, they should be banned. But I'm not in charge of the FDA, and I don't get to make those decisions. I try to keep off my soapbox with that because I think it's all about money, and that's the sick and disgusting part about it. So I'll stop. Let's talk about mood, because when I start thinking about these pharmaceutical companies that are profiting off of women for pure profit, not for the right reasons, it puts me in a foul mood. But oral micronized progesterone is often better tolerated than progestins, but not always. Because when progesterone is taken orally, it undergoes what's called first-pass metabolism in the liver. That means the liver starts to break it down and turns it into certain metabolites, producing in one of those neuroactive metabolites is allopregnanolone, and then there's alloprogesterone. In many women, allopregnanolone helps reduce anxiety, and alloprogesterone improves sleep. This has a calming GABAergic effect. But there is a subset of women, particularly those with mood disorders, a trauma history, or just highly sensitive to neurosteroids. And those ladies can have the opposite effect: irritability, depressive symptoms, emotional flattening, or paradoxical anxiety. So I've heard some women say that when they took the micronized progesterone, they felt crazy. They wanted to kill their partner or something. It was just like sitting there with these evil thoughts. And you take the progesterone, the oral micronized progesterone away, and that went away. So they're metabolizing it the same, but that metabolite is having a paradoxic effect on those women. This is not a failure of progesterone. It's a route of administration issue. This is where alternatives matter. This is where the art of medicine matters. This is where your provider having years of experience to give you different options and explain the pros and cons of those options actually makes a difference. The good news is oral micronized progesterone is not the only option. Vaginal progesterone, there's suppositories or gels that can be used. It takes advantage of the vagina first pass effect. So that tissue in the vagina is mucosal tissue. It absorbs very, very well. Um, and it's directly delivered to the uterus. So we're going to get direct protection. I don't think that our serum levels matter as much with the vaginally delivered progesterone. There's minimal systemic and brain exposure. So those symptoms that we just talked about that were the opposite or paradoxical symptoms will be alleviated. There's lower circulating neurosteroid levels. Again, so that lab level is not going to be as important as long as we know and we confirm with the patient that she's indeed utilizing it on a nightly basis or nearly every night. Key benefits to this is it's an effective endometrial protection. There's markedly fewer mood and sedation side effects. Avoidance of negative central nervous system effect that was seen with the oral dosing. So it really is a beneficial way of administering it. But the downside is for a lot of ladies who are in perimenopause, menopause, and we give them progesterone, one of the most magnificent things that we see is the improvement in sleep. This is not going to have that effect. So if you're suffering from poor sleep due to imbalances in progesterone and you can't tolerate the oral micronized progesterone, will protect your uterus by giving an intravaginal progesterone. And then we might have to come up with some other processes or interventions to help with your sleep. As I mentioned, the plasma progesterone levels remain low, but uterine levels are sufficient, a well-documented phenomenon in the literature. This is often the preferred option for women who say progesterone makes me feel worse. There's another option as well. Low-dose progestin devices. So these are like the contraceptive hormone rings. So low-dose levonorgestrel intrauterine systems or rings provide strong local endometrial protection, very low systemic estrogen opposition requirements, kind of like the vaginal estrogen or the vaginal progesterone, excuse me. However, and this is crucial, large national cohort studies from Denmark and Sweden show small but measurable increases in breast cancer risk, approximately 13% higher relative risk with continuous LNG IUD use, so that progestin IUD use. This risk is far lower than with oral systemic progestins, but not neutral, especially in women with elevated breast cancer risk. So if you were a woman who had BRCA2, which increases your risk of breast cancer, and you could not tolerate oral micronized progesterone, I would not recommend using the low-dose hormone-based IUD because it will increase your risk of breast cancer 13%, according to these European studies. And once we know this, to me, it becomes unethical to make that recommendation because we took an oath, first do no harm. And now by knowing this information and that it does increase that risk, we don't want you doing that. That's my position. Your doctor may have a different position, and that's something for you to have that discussion with them. However, if you're going to have that discussion with your doctor, I would recommend looking up these studies from Denmark and Sweden and bringing them with you so when they negate what you tell them, you can give them the study to read and help enlighten them. And hopefully you'll have a physician who is open-minded enough and understanding enough to take the literature and read it and learn something from it, as opposed to other physicians that I've heard of that when we've given studies to patients to share with them, they look at the study and throw it in the trash because it goes against their confirmational bias. Again, I'm sorry I'm digressing, but these are important things to look for in your healthcare provider. You want somebody who is open to making sure that you are taken care of to the best of their ability, and if they don't know, at least they're willing to learn something. Because you as the patient, you're hiring that individual, and you can fire them just as fast. Back on topic. These options should be viewed as risk stratified tools and not default solutions. Uh, Somebody watching may say, well, I use a progesterone cream and my doctor said that that will work. Um, I, as mentioned before, progesterone creams, unless they're put in the vagina, do not show improvements in serum progesterone levels. So if you're putting it on systemically, and you're not seeing an improvement in the serum level to be at that threshold of 3 or better, I submit to you, you probably are not getting the protection of the uterus that someone might tell you that you're getting and that you think that you're getting. So I am not a fan of transdermal progesterone. That's based off of all of the literature I've read and the teachings that I have had over the roughly 20 years I've been doing this. Someone can disagree, and I welcome that disagreement, but that is my position. Option 3 is sequential or intermittent progesterone regimens. And we utilize this a lot. So cyclical usage of progesterone, I like doing it days 15 through 27 of the cycle. So it's important for women to utilize like a menstrual cycle tracker, like period tracker. There's a plethora of them that you can look up and then you start it on the night of the 14th or 15th day of your menstrual cycle, and then continue it for 2 weeks and end it on the 27th. So day of your cycle. So on the 28th day of your cycle, you should start with menstrual bleeding. For some women, this can reduce exposure time to the micronized progesterone, um, or using it cyclically rather than um, contiguous progesterone can improve tolerability, though this still requires individual supervision. So um, that's why in our practice we utilize labs and we listen to the patient. And if they're having problems with it, one of our first things will be, let's use it cyclically and see how that goes. And if that doesn't work, then we can try some other methods. But again, this is something that is very personalized between you and your healthcare provider. The bottom line, micronized progesterone does not equal all progestins or all progestogens. So you want micronized progesterone. Breast cancer risk is significantly lower with micronized progesterone than with synthetic progestins. Not tolerating oral progesterone does not mean hormone therapy has failed. It just means we need to find another route. Vaginal progesterone is well studied and an underutilized option. Low dose progestin devices do play a role and can be useful, but require informed consent and risk assessment. The real problem in menopause care isn't risk, it's false equivalences. Progesterone is not just one drug. It's a category with radically different effects depending on molecular structure and delivery route. When women say progesterone makes me feel awful, the answer isn't to stop listening. The answer is to choose a smarter formulation for that patient. That's evidence-based medicine. If you want some references for this one, it's the E3N cohort in progesterone versus progestins and breast cancer research and treatment. The British and so that was the publication is breast cancer research and treatment, and that was the French E3N cohort. the British Medical Journal analysis on progesterone versus progestins. There's also a systemic review of the breast cancer risk. And there's an article in Climacteric, vaginal progesterone and first pass effect. And then in JAMA and the American Journal of Gynecology, Obstetrics and Gynecology, was the study on the LNG, IUD, and breast cancer risk. So I hope you find this episode informative. If you have further questions or are interested in having a personalized bioidentical hormone replacement therapy looked at, discussed, initiated with you, please feel free to call us here at Ageless Forever, 702-838-1994. That is if you live in Nevada or Arizona. Or you can go to our website, www.agelessforever.net. We'll be happy to help you. Otherwise, if you're not in either of those states and you're looking for a healthcare provider that can help you and is well versed in this, there are many organizations to look at, but 3 that I have either I am currently involved in or have previously been involved in, and I appreciate the degree of training that they offer, are World Link Medical, um, American Academy of Anti-Aging Medicine, and American College, AMMG, American Age Management Medical Group, or Age Management Medical Group. It's not AEMG, it's AMMG, excuse me. Sorry, folks, if I butchered your letters, but AMMG, Age Management Medical Group. But look for a provider who is certified, and that means that they've at least taken a written test, a lot of them an oral test as well, to kind of validate their understanding of hormone replacement. We all have different ways of doing it. There's no one right way. You have to find the way that works best for you, but find a provider who's well-versed and open to considering different ways that maybe you would prefer. I didn't talk about some other things like pellet therapy and things of that nature. There is no pellet therapy for progesterone, but there's other ways of delivering hormones. I just wanted to cover some of the most common. Thank you again, and we'll see you for our next episode, which will be episode number 47. And I have yet to come up with my topics for that, so we'll see you soon. Thank you.